more on the left side. Ocular movements normal. Okay, that's in short the findings. She is bilateral ptosis left more than the right. Left frontalis overaction. Incomplete burying of eyelashes bilaterally. However, the parodorbicularis appeared normal. Query mild facial, lower facial deviation to the left side. Sorry. So, what is the likely diagnosis in this patient?
Sir, is there an history of fatigability?
She says it's more after reading for some time, but there is no definite variation from morning till evening.
We like to consider.
Pardon?
Diplopia, sir?
No diplopia. She only came with ptosis.
Okay, sir.
So the on localization, sir, ptosis may be either due to a muscle proper cause, it may be neuromuscular cause, it may be due to a nerve cause. So out of all these things, the neuromuscular cause like myasthenia will be first probability.
Yeah, absolutely correct. Absolutely. So that is the first possibility. So what do you like to do now? We test for fatigability, no? Okay.
Yes, sir. Yes, sir.
So I look for fatigability. I'm asking to keep on looking upward. There is some suggestion of a fatigable ptosis, but not definite. Slightly more drooped on the left side. Yeah, slightly more. Not very convincing, but still it is. So, are you convinced about the fatigability? Not very much.
Not convincing.
Not convincing. So, suspicious fatigability. So, we are not sure. So, what else you want to do in this patient?
Ice pack, sir.
Okay, ice pack test was done. This is before ice pack.
Before ice.
Okay, then I will show the picture after ice pack. It's essentially same, not a difference with ice pack test. Almost same. If at all mild worsening, that's all. So what next?
Any childhood photo, sir?
Pardon?
Any photo? Childhood photo?
Photo is not with her.
Family history?
No family history of any ptosis.
Sir, we can go for one repetitive nerve stimulation and one trial dose of pyridostigmine.
Okay, so RNA was done. He said nerve condition study normal. Darkness was also negative. What else?
Sir, trial of pyridostigmine
Trial of pyridostigmine.
Yeah, you can give that, but before that, do some more tests you can do, no?
Acetylcholine receptor antibody we can test.
Yeah, acetylcholine receptor antibody we can do. That only already somebody has done it and it came as negative.
What about a MRI brain?
Okay. MRI brain. This MRI, the films I did not take anyway. Anyway, MRI brain did not show an obvious abnormality in the parenchyma.
So what is about the anti-marks and anti-LAR?
That I did not do. When I always think of clinically, I'm basically a clinician. So I always look at various other causes, try to diagnose clinically.
EMG, any role, sir? EMG?
EMG for what?
Any to rule out any blepharospasm like that?
Yeah, that we can do. Okay. Now, what do you want to do now? Let us look at the video once again. Now, this is what I want you to see. Clinically, you have to suspect something and investigate further. Now, let us see the video once again. He has got elevation of the frontalis on the left side, no?
Elevation is decreased compared to the right.
Right? You all observed that thing. Okay, that could be compensated to the ptosis, correct?
Yes, sir.
Okay, right. Is the eyebrow elevation compensated? That's the first thing. On the left side, it is not compensatory. You know the reason why? Suppose you have got a ptosis on one side. If you want to elevate the eyelid by over a frontalis contraction, always it is bilateral contraction. It is very difficult for one to contract only one frontalis upward. This very, if it is it was compensated, the other eyebrow should have also been gone up. It is difficult for one to keep one eyebrow alone elevated.
Once more, can you say that frontalis?
Because suppose you have got a ptosis on one side. I also thought of another case also. One side, and if you want to, you are not seeing with that eye, what will you do? Try to elevate the eyelid by frontalis contraction. When you elevate the frontalis contraction, you are contracting both the frontalis simultaneously, not one side. Try elevating only one frontalis on your face. Very difficult, no? You cannot elevate one frontalis alone. Right?
Yes, sir.
Yeah, because human the upper motor neuron orientation is oriented in such a way that it produces movement pattern, not individual muscle contraction. So human lesion will produce paralysis of movement and not individual muscle paralysis. So individual muscle contraction by human is very difficult. So you can see upward movement, downward movement, upward elevation of the eyebrow. Those are all human, can be done human, but only one muscle contraction by human is difficult. Okay, just like asking you to contract only one lateral rectus. It's not possible. Usually when you look to the right side, along with the right lateral, left mid lateral is also contract. So it's only a simple thing which may think it's unlikely to be a overaction. Now the thing is, I also thought whether it's overaction, then subsequently found it cannot occur like that. Now, what clinical test will you do to prove or disprove this point? It is actually an overaction or due to voluntary overaction or a real abnormal elevation.
Curtain sign things, sir.
Curtain sign is only for myasthenia, but curtain sign is not there in this patient. Simple things. All the clinical points which I'm mentioning are all based on common sense only. You close that eye and see whether the frontalis elevation disappears or not. It's not simple. Why is elevating the frontalis overaction is occurring? Because of the ptosis. Okay. You voluntarily close, ask the patient to close one eye with the other your hand. The frontalis overaction should disappear if it's a compensatory elevation. Correct? Because once you close one eye passively or with the patient himself, there is no need for the frontalis to overact. Because he is not trying to open the eye. So what will you do? Let us see. Even with closed eye, her frontalis seems to be in the up position. Let us see. It's elevated on the left side compared to the right side.
Whether it is compensated or
Let us see the next video. I'll show the same video, another video. I'm closing the left eye, the frontalis remains elevated. Even by closing the left eye, the frontalis on the left side remains elevated. See, that is compared to the right side. So that means that the elevation is not compensatory. Something is abnormally contracted in the frontalis.
But she is looking up now.
Yeah, but even looking up, it should be similar, no, on both sides. But left side eyebrow is elevated compared to the right side. So what will see? Now let us see the video once again. Now you will understand that thing. Now look at the video, same video which I shown earlier again, once again. Look at the upper and lower eyelid of the left eye. Is the lower eyelid also up compared to the right side, or both sides are up? Anyway, I'll show one more video. There is lower eyelid contraction, facial movements towards the left side, some facial elevation on the left side. And see the puckering of that skin fold on the left side, indicating orbicularis oculi over contraction on the left, on the inferior part also. In a ptosis, you will never get contraction of the lower eyelid because there is elevated percularis superior only for the upper eyelid. The next video now shows that the lower eyelid contraction is present on both eyes and is aggravated by doing other tasks like asking the patient to show. This was there in the first video. When I asked the patient to show the teeth, we look at the teeth or the lower face. We never look at the upper part of the face. Now look at what the same video which I shown earlier. Look at the. What is happening? See look at the orbicularis on both sides. The eyebrows has come down and become narrowed. Correct? Don't look at the lower part. Look at the upper part only. See the contraction of the orbicularis oculi. The palpebral has become narrow now. Now you know what is the diagnosis.
Synkinesis.
Not synkinesis.
Blepharospasm.
This is a blepharospasm. Yeah, blepharospasm.
Blepharospasm.
Yeah, right. As Mohan sir was suspecting, this is a blepharospasm. That is nothing but a focal dystonia. See here, the curious fact is that when blepharospasm occurs, usually the eyebrow will come down. That is because of the dystonic contraction of the both orbital part and the palpebral part. That is usually blepharospasm like this. But here what happened is that the overaction or the dystonic contraction is only for the palpable part of the orbicularis oculi. So what will happen? Only the eyelid will come down, the frontalis will not, the eyebrow will not come down. Simultaneously, there is contraction of the frontalis, that is, the eyebrow is also going. So there is a dystonic contraction of the frontalis as well as the palpable part of the orbicularis oculi, not the orbital part. That you will say disparity is coming. See the eye is coming down, become narrow. So now how to confirm it now? Whether you are, I'm postulating all these things.
EMG, sir.
Yes, very good. EMG the eyelids. And which eyelid will you do? It is the lower eyelid you have to do, because lower eyelid is the one which has nothing to do with the ptosis. If there is overaction of the lower eyelid, it's pakka certain that it is blepharospasm. Okay, so it is the EMG from the lower eyelid I did. I will show the EMG. Even the resting, but there is a continuous motor activity coming. Now it's become more that's a blink between the larger. And after some time, when the spasm comes, it becomes more. That's a blink only. Now it's become more. See, the contraction become more without asking to do anything. It will become more. So the resting position itself, there is motor overactive is coming. Then it is the right lower eyelid also I did. Ask you to keep eyelid still. And still you can find motor hyperactivity is coming on the That is on the right lower eyelid. Then it from the upper eyelid. Upper eyelid it was not much, only very minimal overaction. But only when the dystonic contraction occurs, the activity will be seen. So what is the final diagnosis? Blepharospasm.
Blepharospasm.
Yeah. And she was put on pacitine and she removed remarkably well with usually they don't respond very well to pacitine. But sometimes, these people focal dystonia do respond. So luckily for her, she responded to pacitine.
So
okay.
How to differentiate it from functional?
See, again, one point, one cannot make a functional elevation of one frontalis alone, right? Otherwise, somebody comes bilaterally with a blepharospasm, definitely can be confused with function. That's why, just like as I told last time, any involuntary movement can be functional. Dystonia, chorea, tics, all can be Parkinson's. Everything can be functional. But when it does not tally with or agree with the physiological nature, then you have to think of function, an organic condition. For example, elevation of one eyebrow alone. Some people may be able to do that, but that's not common. And moreover, we have got electrophysiological evidence that it is overaction is there. And she's asked to show the teeth, the eyebrows contract. But if it's a functional patient, that will not occur.
Sir, is there any history that when she goes out in the sun, is there any increment of your blepharospasm? I mean, exposure to sun. Generally, they will functionally blind ultimately, no?
What you said is correct. Usually, blepharospasm get aggravated when they walk in the sun. That history, frankly, I did not ask the patient because she was referred as ptosis. I was not concentrating on the ptosis. This thing came only after examining everything. This struck me by this upper eyelid is elevated. So I did not go back and ask the history once again. I should have asked. Okay. Any questions? Any doubts?
Any role for botulinum?
Yeah, but since next step is botulinum toxin, but since he responded, we can defer botulinum toxin. It's not tolerating, you can go for Botox. Now I'll show you another video. Let us see. What do you think about this patient?
ഇവിടെ നോക്കമ്മ ഇവിടെ
Her ocular movements are all normal. What is your diagnosis in this patient? She also came with the complaint of ptosis of right eye.
That was the size of the pupil, sir?
Normal.
Normally reacting people.
And normally reacting, ocular movements normal.
Yes, sir.
The apparent exophthalmos of the left eye, sir.
Yes, sir.
Yeah, it could. Yes, you're right. You're right. So there are two possibilities. That is this just I will show the video once again. So I did not show the video. Sorry, I did not show the video once again.
ഇവിടെ
Okay. So is it ptosis of the right eye or the eyelid retraction on the left eye?
Both are possible, sir.
Both
Yes,
are
sir.
possible. Yeah,
Both
both
are
are possible. Both are possible. Now I want what clinical test will you do now to differentiate the two?
Sir, is there any lead lag?
No lead lag.
All
Compare with
extraocular muscle movement normal.
Normal.
Compare with previous photos, sir.
Pardon? Same thing, same patient photo. This is a fee. Same thing.
No, sir. Compare with the previous photos of the patient, sir.
That is not available. I'll show you the next part of the video, then make you understand. So what clinical test will you do? Let us see what I did. I close the right eye. The left retraction disappears. What does it tell you?
Right eye ptosis, sir.
That means it's not that the apparent lid retraction was a pseudo-lid retraction because the patient is trying to elevate the right toast eye on the right side. In an effort, both frontalis will contract. This again exemplifies and tell you that when you try to elevate your eye, correct the ptosis by elevating the frontalis, it will contract bilaterally. That is why this phenomenon is occurring. Now let us see what happened. So close the right eye. Now when you remove the eye, see, she's trying to elevate and you get a right eye is already toast because of the ptosis. The left eye is she's trying to elevate. You can see the clear eyes become visible. Correct?
Yes,
So what is, yeah. So this is a simple bedside test which you can do to find out whether it's lid retraction on the left side or a ptosis on the right side. And this test is very classical of seen in myasthenia gravis. Okay.
It is like lateral pulsion, no, sir.
Pardon?
It is like confirming the lateral pulsion, no, sir.
No, it is not lateral pulsion. It's actually, it's
In
only,
lateral pulsion also, sir, lateral pulsion also after covering one eye, the another eye becomes the lazy eye will come to the primary position, no, sir.
yeah, that is a different thing, no? That is related to the ocular movement. This is in
Okay,
relation with the ptosis only.
Okay, sir.
Yeah, because here what is happening when your one eye is toast, you are not seeing clearly with that eye because that eyelid is covering. What will you do? Naturally, you tend to elevate your eyelid by frontalis contraction. Since it's occurring bilaterally, you cannot contract on unilaterally. Both eyelids will go up. Eyebrows will go up. So the left eyebrow is going up in a normal eye. So what will happen? The sclera will be visible on the normal eye. The toast eye will be, so it appears like a lid retraction. And this sign is called the pseudo-von Creeps sign or pseudo-von Creeps sign. Von Creeps sign is used in thyrotoxicosis, lid lag. So here it is pseudo-lid.
Thank you, sir.
പോയിക്കൊണ്ടിരിക്കുക.
When open it,
Yeah,
see
okay.
trying to elevate, see both.
വരലും നോക്ക്.
See the both orbicular, frontal
മുകളിലോട്ട്.
contracting. So not only one side.
Becomes one.
That is how the previous patient, one-sided contraction is almost always a dystonic contraction. Now this again comparing with the closing the toast eye, there is no overaction of the frontalis on the left normal eye. On removing the cover of the toast eye, there is overaction of frontalis on both sides. Clear? On removing the cover of the toast eye, there is overaction of the frontalis on both. See that the eyebrow is elevation is symmetrical on both sides. It is not unilateral.
There is some fatigability also, sir.
Yeah, this patient has also got a fatigability. That I did not want to, David did not show. Our previous patient, the blepharospasm, see on the again, eyebrow remains elevated whether you close that eye or not. That is suggestive of a blepharospasm. Okay, so that's regarding the first case.
But in the first video, there is some Kogan's eyelid twitch, like twitches.
Yes, it is there. Yes, I did to sign is there on the right side, again indicating some fatigability of the muscle.
Can you show that, sir? Hogan's eyelid.
The first one. I'll show that.
Twitch was there.
Yeah. And if you look carefully, there is some slowing.
ഇവിടെ
also
നോക്കുമ്പോ.
on the right side.
ഇവിടെ.
You see that it's on the right side.
That's
Yeah, that one. Going up and coming back like that. That's Hogan's little sign.
Yeah, twitch sign.
Don't look at the left eye, look only on the right eye.
ഇവിടെ നോക്കുമ്പോ. ഇവിടെ.
It is coming down. Acute upward movement, that eye will come down. Eyelid will come down. Okay. Any questions? Okay. Shall we go to the next case?
Yes, sir.
Okay.
Second case was myasthenia, sir.
The second case is a myasthenia. Because
Okay.
the one Greaves sign is also described in myasthenia. But can occur other ptosis as well, it can occur. This is a story.
Blepharospasm
please.
is always bilateral, sir.
No, that's what our patient only unilaterally. In fact, it is present bilaterally, but more on one side. But the frontalis contraction is asymmetrical only on the left side. That is not there on the right side. But the
But
palpable
TMG showed spontaneous activity and bilateral, so that's why I asked.
that was on the palpable part. That's what I said. There is a blepharospasm of the palpable part of the orbicularis oculi bilaterally.
Okay,
But
sir.
the frontalis overaction was only on the left side.
Yes, sir. Yes. Okay, sir. Thank you, sir.
Yeah. So this is a story of a 65-year-old lady. In fact, she had been under my treatment for Syringomyelia for the last 10 to 12 years. She lost all her records. The only previous prescription available with her was one dated 11/9/2016, This is because she came to me after 2016, now after so many years, with another complaint that really showed the old prescription. In that prescription, it was written old case of Syringomyelia. Her main complaint must have been pain in the right upper limb since she had been on gabapentin. So that prescription carried gabapentin. So must have been having some neuropathic pain. Apparently, there was no weakness and a DTA were noted to be normal except for decreased biceps and tricep jerk. So this is my old prescription. To remember October 2016. I just written cervicosis Syringomyelia, presently asymptomatic. That's all. And gabapentin. Now she has come presently with the complaint of weakness of right upper limb in the form of difficulty in elevating her arm and taking food to the mouth. This was noticed 2 days back. No pain or any other complaint. No weakness of any other limbs. So this is the video of the patient. Cranials are all normal. There was no Horner syndrome. Parietal movement is also normal. Tone was normal. Here, deltoid is weak on the right side. Left side normal. That is weak on the right side. Sorry. Biceps was normal on the left side. It is almost normal. Mild weakness was there. Biceps was normal bilaterally. Radiculopathy is also normal bilaterally. Normal brachyradially. External rotation is normal on the left side, weak on the right side. It is weak on the right side. Extensor wrist normal. Extensor digitorum normal. Long finger flexus normal. Almost also normal. Lower limb power was normal. Reflexes, biceps as absent bilaterally. So also supinated jerk. But see the finger flex is correct. I see inverted supinated. Triceps as well elicited brisk bilateral. There is a finger flex is absent. But there is inverted supinated. See the inverted supinated. On the right side, biceps is absent, supinator is absent. But again, there is a inverted supinator jerk on the right side. Triceps is brisk. Knee jerk was brisk. Plantar was indefinite. The sensation normal. See, pain sensation is normal on both upper limb. She says no difference. It is same. But vibration is left is feeling, right side not able to feel. Yes. No. Yes. Yes. No. No. All the fingers is not able to feel vibration. No on the second. Absent in the elbow. Even the shoulder it is absent. But the left side is consistently present. The right knee it is absent. Left is able to feel. But she is able to feel vibration over the foot. Able to feel the cold sensation on the right side and both sides. She said correctly on the left side. Right side she made mistake.
അറിഞ്ഞൂടെങ്കിൽ അറിഞ്ഞൂടാ ഇപ്പോഴോ
She is not able to
ഇപ്പോഴോ
feel. Able to say correctly.
ഇപ്പോഴോ ഇപ്പോഴോ
She is not able to feel the joints in the right upper limb.
ഇപ്പോഴോ ഇപ്പോഴോ
Again made mistakes on the right foot.
ഇപ്പോഴോ
Left side she said correctly.
ഇപ്പോഴോ ഇപ്പോഴോ ശരി
There was I couldn't make out any winging of the scapula or anything grossly.
പൊങ്ങട്ടെ
There is no serratus venial weakness also. So an examination, upper limbs tone, normal tone, both upper limbs. Right upper limb, weakness of deltoid, right external rotators of right upper limb. Cori, mild biceps weakness. Other muscles are all normal in the right upper limb. Left upper limb, all muscles normal. Lower limb, normal power in both lower limbs. So infant motor system weakness only for the deltoid and external rotators and supraspinatus. DTR, both upper limb biceps supinated reflex absent. Inverted supinated chest bilaterally. Triceps bis bilaterally. Finger brushing, however, is absent on both sides. Both lower limb, both knee jack brisk. Ankle jacks normal. Plantar both indefinite. Temporal sensory system, touch is normal in both upper and lower limb. Pain is also normal in both upper and lower limb. Temperature also normal in the upper limb. Vibration impaired in the right upper limb in all fingers, elbow, and the shoulder. Impaired in the right lower limb or the right knee and the anterosupplex spine, and felt feebly over the ankle. GPS impaired in all the fingers of the right upper limb and normal in the left hand. And the lower limb, it is impaired in the big toe of the right lower limb, normal in the left lower limb. So vibration is impaired on the right side of the body, except the distal part of the right foot, where it's mildly affected, and impaired joint sense in the whole of the right upper limb as well as the right lower limb. Stance normal, rhombus is negative, gait normal, tandem walking normal. So where is your localization? Forget about my old record, which may not be correct, but presently, what do you think?
Sir, dissociative anesthesia is there, sir?
Yeah, she has got normal dissociation in the sense that pain,
Yes, sir.
temperature, touch is normal, impaired vibration and joint sense on the right upper and lower limb.
Biceps absent also C5.
Biceps and supinated
break-
absent bilaterally, inverted supinated jack.
C5, sir. C5,
Okay.
C6.
So
Motor.
C5 is motor, right. Spinal cord. Is it a lesion inside the cord or outside the cord?
So the patient has got features suggestive of both myelopathy and radiculopathy. Myeloradiculopathy.
Perfect. So C5, C6 radiculomyelopathy. That's a
Yeah.
localization.
This is the term.
The commonest cause is spondylotic, no?
Commonest spondylotic.
Okay. Any other thoughts by anyone?
For C5-6 now, sir, brachioradialis is normal now, sir.
Yeah, Victor is also normal. Biceps also normal. Almost
For
normal.
C5-6, it has to be weak now, sir. C5-6
Yeah, the problem with biceps and infantile spine is definitely weak. Bicep, deltoid is also not totally weak. It is about 3 plus to 4. But you've got a very good valid point. So what do you like to think in this patient?
Any plexus, sir, but the lower limb vibration cannot be explained.
Yeah, whole right upper limb vibration is lost, Johnson's is lost. And the reflex has got inverted supinated bilaterally. Okay, any other thoughts? Nothing. Okay, let's see. So bipyramidal signs with predominant posterior column affection on the right side. Weakness of right delta and external rotators, inhibit superior bilaterally. So cervical radiculomyelopathy, etc. That is your, normally one should consider that possibility. But there is something odd that about, I will tell you, come to that later on. What do you want to do now?
For imaging studies, sir.
Okay.
MRI of the cervical.
Right, very good. So in fact, patient was asked to bring the old MRI. This shows under my follow-up. I send her back, bring all the MRI and take a new MRI also. So this is the old MRI taken in April 2015. This is the MRI picture showing this is T1 showing a hypo-intense lesion extending from C2 downward up to D3, lower, whatever segment is seen up to that is there. Large diameter hypointensity was seen over the D1. This is the T2 weighted sequence. Hyperintensity, at the lower part there is hypointensity here. This is again another cut. This is some other, I think it's still sequence. This axial cut from above downward, again the old one. This is C1, C2, C2, C3, 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 C4. Left one is C4, middle C4, C5, last one C5. Again C4, C5, 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 C6, C6. And there is a hypointensity within the inside the cord. And this is T2. Remember, this is a T2 weighted sequence. Again, you can see the C7, D1, there is hypointensity. So contrast was also done at that time. There was no contrast in that segment. And say, yes, what do you think the patient must have been having previously? Pardon?
Tonsils are low-lying, sir. So was there Arnold sharing?
Yeah, there is Arnold cherry. Correct. You're right. There is Arnold cherry. It is tonsil is low down. And
Any
there
mass
is
lesion, sir?
Pardon?
Any mass lesion around T1, sir, intramedullary, sir?
There is a Syringomyelia, cavity lesion inside the cord, which has been there for so many years. And with Arnold cherry malformation, the first possibility is a Syringomyelia itself. May I ask you one question? Why in Syringomyelia in T1 shows this hypointensity within the hyperintensity? That you can see in the axial cut also. See the axial cut.
Artifact, sir.
It's well described in Syringomyelia. This is because of the flow voids. When the fluid is large, the fluid is not stagnating, moving up and down, you get a flow void. Just like the thoracic cord, thoracic T2 scan of the thoracic spine, you find multiple flow voids outside the spinal cord. I'll show the picture. This is the content. This is the hyperintensity due to flow voids. Now, what about, what do you think of that's already true? What is the Syringomyelia? Was it Syringomyelia? You agree with that? Yes, it is shared extension.
Yes, sir.
Yeah, Syringomyelia. Now, we'll try to correlate the clinical picture later on. Now, this is a second MRI taken in December 2024 when she came with the weakness of the right upper. Same thing, you can see it. This is the T2 space. The Syringomyelia cavity is little more increased lengthwise. Longitudinally, little more prominent than the previous one. But at that time, the space sequence was done. This is the axial cut. That is a flow void inside the syrinx. You see the dark one. This is the T1. This is a T1 axial. Hypointensity will become very prominent now compared to the previous one. But the extent of syrinx remain the same. So comparison with the previous one. The left one is the previous one, the right one the recent one. And not much of a change. So what do you want to do now? Center for surgery.
Nerve conduction study.
Nerve conduction. Okay. I'll do the nerve conduction for you. Before that, NCS was done. This is NCS. Right median. Of course, forget about the carpal tunnel syndrome. Right radial normal. Axial hypertension is normal. Respiratory normal. Sensory all normal. Except the antibrachial is slightly low, but again within not more than 50% difference.
Detailed
Yes,
study of CVJ.
Pardon?
Detailed study of the CV junction.
FA, sir.
CV junction shows subnodal malformation.
Axial cuts.
Axial cut that's only cut available.
Suprascapular nerve, sir.
FA, sir.
Suprascapular nerve.
Suprascapular nerve. That was not done. So, what do you want to do now?
What was the duration of weakness?
Oh, only 2 days, 3 days, maximum 3-4 days before she came to me.
Wait for 2 weeks and then repeat.
Pardon?
NCS. Wait for 2 weeks and then repeat an
NCS. Yeah, correct. That's a good way of thinking about it. Very good, perfectly right. Unless it's a demyelinating disease, sometimes we will not pick up, only later on it will pick up. Demyelinating can be picked up if you stimulate proximal to that.
Will be a stroke or something?
Brain, okay. This is 3 days after follow-up. I mean, 3 days, sorry, my grammar is correct. This is 3 days after treatment. So the patient was given treatment for 3 days and the patient was seen after 1 week. The third day is improved. Biceps are totally normal. Acceleration was better than before, not totally normal, better than before. It was done for her.
Brachial neuritis.
Exactly. She was given 3 doses of IMB. Somebody mentioned this point correctly earlier because, always clinical points are the one which give you the diagnosis. No amount of investigations. So what is the point again is C5 radiculopathy. She had weakness of the right deltoid and infraspinatus sparing of the biceps and radiculopathy. That is the point. Okay. So if it's radiculopathy or upper trunk involvement, you expect to be this thing. Such a selective, anytime I told this particular point, the commonest pattern of neurologic hypertrophy is delta axillary and suprascapular nerve. This combination is the commonest one. You can any combination, that's a different thing, but it's a commonest combination. When you get set in such a pattern, always think of a brachial neuritis. And this does not fit with the C5C6 radiculopathy. See, there is a part of examination which I did not share earlier.
ഈ കുത്തുന്നതും ഇതൊക്കെ ഒരേപോലെയാണോ?
ഇത് അത്ര പോരാ, ചെറുതായിട്ട്
ഇതും വ്യത്യാസമാണ്.
ഉണ്ട്.
She has got a sensory loss over the lower bundle. When they examined initially, she was telling everything is normal. So when they understood selectively look for that particular sign, then there was decreased. Old Syringomyelia with recent neurological hypertrophy. Now the point I'm trying to say, see, we have been taught that Syringomyelia always had dissocial anesthesia and all. See that you not see for look at this patient. She had posterior column involvement on one side with normal pain sensation and temporary sensation. And she has got a central cavity. I do not know how to, if you ask me why those sensations spared, I cannot explain. So these disparities of many a time I have seen loss of vibration joint cells in the upper limb in persons the affected area of the cells. Probably the extension backward. Remember that Syringomyelia is not equivalent to hydromyelia. In hydromyelia, this situation cannot occur. Because hydromyelia is just dilated to central canal, we expect dissocial anesthesia in the segment it is involved. Like the band-like or a band-like or what you would call jacket-like sensory loss. Dissocial anesthesia. But in the Syringomyelia, cavity need not be around the central canal, maybe outside. It may be usual situation is the base of the dorsal horn. That is where the usual Syringomyelia cavity initially starts. Some more of that cavity that spread to the posteriorly, prominently, rather than going to the center region. This is not the usual presentation, I agree with the totally unusual presentation of Syringomyelia, but she was already diagnosed earlier, and this is the finding.
So Arnold theory can cause myelopathy and posterior column involvement.
Yeah, but here it is something because she had no pain sensation, only posterior column is affected, and there is a lesion extending from that area downward.
Arnold theory causing cord compression.
Yeah, that can, but this you confine only to the right side, not on the left side. That you can explain, but one side is affected a lot. Okay, any questions?
So how was the pain in the nape of neck and the other arm?
No, there was no pain or anything on the other arm. Only she came with mild pain in the right arm and then weakness. And pain is also not a prominent pain.
So pain sensation, sir. Pain sensation examination.
Normal. Pain sensation is normal. This I had shown earlier. I will show you.
ഇതൊക്കെ ഒരേപോലെയാണോ? ഇതൊക്കെ അറിയാവോ അമ്മയ്ക്ക് പേനയൊക്കെ ഒരേപോലെയാണോ? ഒരേപോലെയാണോ? വ്യത്യാസമില്ല. ഇതൊക്കെ അറിയാവോ? ഈ കുത്തുന്നതും ഇത് ഒരേപോലെയാണോ? ഇത് ഒന്നുപോലെയാണോ? ഇത് രണ്ടും ഒന്നുപോലെ. ഇപ്പൊ അറിയാം ഒരു വൈകമ്മ.
Okay, any questions in that case?
So brachial neuritis also can cause contralateral involvement.
Yeah, it can be. It can be unilateral, it can be bilateral. Many a time, if you closely examine, you can have weakness of the contralateral infraspinatus also. Then we seldom do that. If you examine closely, you can find out that also. Okay. Shall I go for one more case or stop? I think one more case is possible. One more case. Any questions in this patient?
Facial sensory loss, sir.
There, in this patient, there was no facial sensory loss. Corneal reflex was normal because I did not show the entire thing, but it was done because in the sensories normal, I only look for, showed you the palatal weakness is not there. No features of Arnold Syringomyelia clinically.
Sir, hydromyelia is always central.
Yeah, correct.
And syrinx may be either on the posteriorly sideways or in the center.
Yeah, correct.
So the phloboid will be more prominent in case of your syrinx or hydromyelia.
Syrinx. Wherever there is a large quantity of fluid is there which is moving, it can produce phloboid. It can be seen also in hydromyelia. It can also be seen in syringomyelia.
Thank you, sir.
Okay, shall I go to the next case?
Okay.
Just one more. Okay. In the story of a 61-year-old male, known case of diabetes, hypertension, and coronary artery disease. His complaint started on 6/8/2024, that is 2 months back, as an acute onset of vertigo, vomiting, followed by unsteadiness in walking. The vertigo subsided in 2 days' time, but left with mild imbalance in walking, requiring support a wall to walk, which is persisting even now. However, 3 days back, the patient had a fall with the right side of the chest hitting on the floor. No history of vertigo at that time. Since that time, patient noticed worsening in walking, with tendency to fall to either side, requiring the support of 2 persons to walk. Initially, he had something like a stroke with the vertigo that subsided. He was able to walk, just holding onto the support without anyone's support. He had a fall on 1 day, 3 days back, following which he needed support of walking. So this is the video of the patient. There was no mourners. Ocular movements normal. There was no nystagmus. Upward movements normal. Then look for saccadic lateral pulsion. There was saccadic lateral pulsion to the left. Look once again. See the eyes were deviate left side on the closed eye. There is left side palatal weakness. Corneal reflex decrease on the left side. Decreased pain over the top part of the face. That is equal. Power on the upper limbs were normal. Tone was normal. There is no finger nose incontinence on the right side, but there was finger nose incontinence on the left side. Tone the lower limbs normal. Power was normal both sides. There is incontinence the left lower limb. This is positive on the left side. Normal on the right side. That is grossly abnormal on the left side. The reflexes upper limbs normal.
Relax பண்ணுங்க.
Triceps is decreased on the left side. Bilaterally decreased. Finger reflex is also absent. Down reflex is elicitable. Knee jerks were brisk. Ankle jerks were absent. Plantar was subgoing. It's undoubtedly upgoing plantar. Both sides. Touch is normal throughout.
இந்த குத்துந்த வலியும்
Pain is decreased
இந்த
on
வலி
the
கொஞ்சம்
right
வித்தியாசமா
side.
இருக்கா இங்கே கம்மியா ஜாஸ்தியா
இது வந்து ஜாஸ்தியாக இருக்கும்
அதான் சொல்லுவேன் இது ஜாஸ்தியா இருக்குதுங்க
இங்கே தான் வருது
More pain on the left side compared to the right side.
இங்கே அவ்வளோ கரெக்டாக
Lower limb distal impairment of
இந்த
pain.
குத்துது இந்த குத்து வித்தியாசமா
ஆமாம் சார்
எங்க ஜாஸ்தி
லெஃப்ட் தான் ஜாஸ்தியாக இருக்கும்
அங்க ஜாஸ்தியா இருக்கு இங்க கம்மி
All decreased on the right half of the
தெரியுதா
body.
குருன்னு தெரியுதுல்ல
ஆமாம் சார்
தெரியுதா
தெரியும்
Vibration is normal.
வலையெல்லாம் தெரிய மாட்டேங்குது
It's absent on the right foot.
இப்போ
இதுலேயும் இல்லை
இல்ல
Bilaterally absent.
இதுலாம் தெரியும்
Bilaterally present over the angle.
இதெல்லாம் இல்லை இல்லை
பாருங்க இப்ப தெரியுதா
இல்லை
இப்போ
இல்லை
Is absent on the left side.
தெரியும்
Right leg is able to feel, not able to feel on the left leg.
இப்போ
தெரியல சார்
தெரியுது
But toes it is absent bilaterally.
தெரியும் மூளையில் கொஞ்சம்
இப்போ
இவன் தாளாட்டு
இப்போ
இவன் தாளாட்டு
இப்போ எப்படி
தாளாட்டு
Joints is normal
இப்படி
தாளாட்டு
on both upper limb.
மூளாட்டு
இப்படி
மூளாட்டு இப்போ தாளை
இப்போ
தாளை
இப்போ
மூளை
இப்போ
மூளை
He said correctly. But both toes is
இப்போ
absent. Bay.
தாளை
இப்போ
தாளை
He made mistake.
லூஸா போடுங்க இப்போ எப்படி
இது தாளாட்டு
He is not.
இப்போ
மூளாட்டு
இப்போ
தாளாட்டு
He said correctly. Again went wrong. Even if thighs open is mildly ataxic, which is more present by eye closure.
அங்கே வருது சும்மா நிறைய
Okay. He seems to drag one lower limb. Dragging the left lower limb.
மட்டக்கால் வைங்க இந்த இடதுகால் முன்னால் வைங்க மட்டக்கால் முன்னால் வைங்க இந்த மட்டக்கால் வைங்க
He could not walk tandem. I just see the gate once again beside his dragging. Left side was dragging, correct. Left side is dragging. Left side is dragging. So an examination, caleness, no Horner syndrome, mild left lateral pulsion, ocular lateral pulsion, cyclic lateral pulsion, left palatal weakness, decreased corneal reflex on the left side, decreased pain over the left upper part of the face, motor normal tone, the upper limbs dragging on the left foot, power all normal, finger nose incontinence is the left upper limb, heel shunt is positive on the left side, normal on the right side. DTR upper limbs all normal except for the left triceps which is decreased. Lower limb both knee jacks are normal or on the briscus side slightly. Ankle jacks are absent. Abdomen reflex present but sluggish bilaterally. Plantar both ongoing. Sensory system touch normal in both upper and lower limb. Pain impaired in the right upper limb and right lower limb. Vibration impaired over both toes. Also impaired over the left knee and ankle. Normal on the left anti-superior. That is below the anti-superior leg spine, it is decreased on the left lower limb. But on the right lower limb, it is lost only in the toes. Normally felt in the right knee and ankle. JP is normal in the upper limb, impaired over both great toes. Stands mild imbalance with eyes open, increased on closing eyes. Tracking on the left lower limb and is ataxic. Tandem walking is defective. So, if you want to show the findings again, I can show it. So, where is the site of lesion?
So
Yes,
two
sorry.
sets of possible, sir.
Pardon?
Two pathologies are possible, sir. One is posterior
Right.
circulation profile, because the patient had a posterior circulation symptoms previously, so his mild lateral pulsion, right sided hemisensory disturbances, everything can be
Explained
explained by
by
the
the
previous
lateral medullary. Right, very good.
yes, sir,
Lateral
lateral
medullary.
medullary, sir. Left lateral
Very good.
medullary, since he has a palatal palsy, hemiataxia, everything is localized lateral
Yes.
pulsion to the left. So
Very
left
good.
lateral medullary. Since he has a
That's
recent
perfect.
uh, worsening of the
Worsening.
pyramidal symptoms, and the highest level of reflex is only the left triceps is lost. Only we can tell, sir.
Yeah.
So can we possibly put it in cord at
Yeah.
the level?
Definitely we can put in the cord. But the problem here is got to, let us say, analyze the problem. What are the things which find it difficult to explain by a previous lateral medullary infarct? So as you said, left tricep decreased. Okay, old man can sometimes decrease itself. But one thing which cannot explain is the bilateral upgain plantar. Correct? So for that you thought a cord lesion, that's perfectly justifiable. But in acute cord lesion, it all started with a fall. And then is noticed difficulty in worsening in walking and ataxia. The cord lesion to produce difficulty in walking, you said should not only the upgain plantar should have weakness also. But that much of weakness is not there in this patient.
Since he also has sensory components, sir. So his ataxia might be explaining that, sir.
Yeah, but the sensory component is due to the impairment of the pain and the posterior column joints and so the both feet. It's got a peripheral neuropathy. So that's what you think. Peripheral neuropathy cannot occur acutely, no? So it has been must have been there earlier. He's a diabetic.
Okay, sir.
So it's like tricky, But and he was found to be dragging on the left side recently only. Maybe I do not can't be 100% certain. But they might not have noticed also. We also find difficult to notice how can the best under notice. So even though the patient is still like that, we cannot take it, we have to take it with a pinch of salt. So let's see old left lateral medullary syndrome. Cause of recent worsening, maybe another infarct. Okay. The peripheral neuropathy, we are seeing for the first time, the peripheral neuropathy might have been there earlier. So now let's see the patient came with an old MRI. This is the old MRI. Yeah, please.
So way to localize the vibrations, one side it is absent. Sir.
Yeah, that I'm going to explain. See, he has got a loss of vibration below, in the left lower limb, below the anti-iliac spine. The whole of the left lower limb, this vibration is lost. The other bit of vibration can be lost of peripheral neuropathy. Forget about that. So how to explain the loss of vibration? Anyone can explain that thing? If I'm going to discuss that particular point. Can lateral medullary syndrome produce loss of vibration on the ipsilateral lower limb?
Yes, sir. Possible, sir.
How?
Sir, during that sensory decussation, I don't know find the exact location, sir, but it can happen, sir.
You're perfectly right. Because, the lesion is in the lateral medulla. When the lesion extends a little more down, it is going to catch hold of the gracile nucleus. Little more laterally, cuneate nucleus. The gracile nucleus is implicated, you get a vibration sensory loss in the left lower, ipsilaterally. Same token, you can have pyramidal also signs also can occur with a lateral medullary infarct because the lesion is on the lateral side. When descends down, it may catch hold of the pyramidal tract after crossing. That is uppermost part of that is if the lesion extend to the lateral part of the cervical cord, when it will affect the pyramidal tract which is already crossed and reach the same side. So you can have in a submedullary infarct, I'm showing the picture later on. You can have ipsilateral posterior column loss. You can have ipsilateral pyramidal signs. But contralateral pyramidal signs cannot be explained. Again, bilateral upgain.
There was no facial weakness in patient, sir.
No facial weakness. Let us see the old MRI. This is the old MRI. You can see that there's arrow pointed to the infarct of the left lateral medulla. That is the one. Again, you get that one. The rest of the things is normal. That is a diffusion restriction, which you can see the ADC. Now, let us see now, analyze what are the findings which can be explained with the previous lesion. What are findings which you cannot explain? Let us explain that one. So what are the findings which can be explained with the previous lateral infarct? Left tenth can be explained. Left saccadic lateral pulsion can be explained. Decreased pain in the left upper face. Decreased colon reflex. Decreased pain in the right side of the body can all be explained. How to explain the decreased vibration in the left lower limb? The same question was asked by somebody. Can you explain by left lateral syndrome? Yes, if the lesion happens extend to the nucleus gracilis on the same side. I will show the picture later on. This is called subalbar infarction or a Palaski syndrome. Some patients with lateral infarct can develop ipsilateral hemiparesis. This is due to the effect of the lowermost medullary area or the medulla spinal cord junction involved in the ipsilateral corticospinal tract after pyramidal decussation. This is a submedullary infarct. You can see the picture there. Vertebral spinal artery. The clinical features include ipsilateral pain and temperature loss on the same side of the face, as you expected it, Horner syndrome, ipsilateral ataxia, contralateral pain, just like lateral syndrome. But the thing which is odd man out was ipsilateral posterior column, because that is going to implicate the gracilis nucleus, the same side as the lesion. The infarct is just above, descending down, implicate the gracilis nucleus. It may catch hold of the pyramidal tract after crossing. This is the pyramid anteriorly, it has crossed. So the infarct is in this area is the one which involved like that, implicate the pyramidal tract. So what are the findings which cannot be explained in our patient? Bilateral apical panda cannot be explained. Unilateral, of course, left can be explained. Absent angle jack and embed vibrate GPS of the toes that can be explained by the it's a diabetic. It can be explained by spiritual neuropathy. Now, how to explain the upgoing toes and dragging on the left leg? Dragging on the left leg, if it has been present earlier, we can think it's part of the pyramidal tract submedullary involvement. Left pyramidal weakness can also be explained by the previous lateral infarct. But what about the upgoing toe on the right side? Because following the fall is become more unsteady, more difficulty in walking. So there is something which has caused the right upgoing plantar, and the worsening of the ataxia has been occurred. Okay, so what do you want now?
And the absent triceps also, sir, one side.
Yeah, but the absent triceps is there, but that is not going to be symptomatic, because by that alone is no weakness in the triceps. That may give a clue to the localization as regarding the upgoing plantar. But how to explain such a disability without any, say, imagine that patient has got a left tricep loss, cord is compressed. Disability should be due to either a significant weakness or posterior column loss. That's only on one side, vibration such loss. That will not produce that kind of a impairment and difficulty, so much difficulty in walking.
But whether it has taken place after the fall?
Which one?
This present difficulties, it is increased after the accidental fall.
Like how he fell, we do not know. Whether the deficit has occurred and fell down. But what even is, if the fall is responsible for the deficit, where should be the deficit? That's the problem.
So is there any head injury there?
No head injury, no head injury. He fell on the chest. That I have told in the history. He fell on the chest. And no head trauma.
Sir, we'd like to have a repeat MRI.
Right, right. Okay, someone else is asking the question, please.
So bilateral spinocerebellar tract involvement can cause bilateral ataxia, sir. So if there is involvement, if there is an upward extension of the infarct, namely if there is a transverse pontine fibers involved, it can cause contralateral ataxia. Contralateral upgoing plantar can also be explained, sir.
Yeah, correct. What you said is correct. You can. That means another infarct has occurred. Correct.
Yes, sir. The LOC itself is probably a stroke, and this might explain as upgoing plantar on the right, sir.
Right. So there's a recurrent stroke has occurred. But it's particularly correct. That's exactly the strong possibility. Then might have caused the fall. Okay, as sir was telling, we'll take a repeat MRI and see. This is a repeat MRI taken after the worsening. There is a fresh infarct on the right pons. Did you see the acute infarct on the right pons? And not only that one, another in the corpus callosum, another two in the subcortical white matter. There is one. I'll show the static films later on. So this is another fresh infarct right pons. One in the corpus callosum, then another left subcortical white matter. These are all acutely occurred for the 3-4 days following the fall or resulting in the fall. This is in fact the titubated. That's in fact in the flare. Which are present early, we do not know, but there is, this is SWI. This is angiogram. So multiple acute infarcts in the right pons, left subcortical white matter, and corpus callosum. So anything else you need now?
CT angio.
Okay, CT angiotriphosphatase is agreed. And when you get multiple tertiary involvement, always think of cardioembolic stroke. Yeah, so underwent the extensive cardiology workup. So cardiology is normal. So I did a spinal cord study also to find out any lesion there because the triglycerides was decreased. There is another small infarct can make out. It's very difficult to make out here, but there is a small hyperintensity in the lower part of the spinal cord. It may not be there. It may not, little doubtful. This is the one the radiologist pointed out about that hyperintensity. Not very convincing anyway. There is chondrotic compression that could be responsible for the C7 root involvement, but not symptomatic. There's a compression there. That can also explain the upgain plantar if necessary, but the patient's questions got a walking difficulty which has come, that is unlikely due to the cord involvement, acute presentation. That is chondrotic compression. There is some myelomyelitic changes within the cord. So anything else you need now? Whatever from the cervical cord cannot cause a worsening like that.
Rule of dissection, sir.
But it's multiple territories. It is coming one in the posterior circulation, other in the subcortical white matter, in the middle spular territory, one other in the anterior corpus callosum, anterior
So rule of malignancy, sir.
Right. So then one more thing, this of course, we did conduct an NCA study which showed absent pattern, that's unrelated. So you want CT chest and abdomen?
Yes, sir. PET scan, sir.
Perfect. That is the thing you have to keep. Whenever there is an acute onset of rapidly developing artery infarct in multiple arteries, always consider malignancy. We showed a mass in the right cecal region. And it was operated and turned out to be adenocarcinoma.
So malignancy, mets are usually hemorrhagic, sir?
This is not due to the metastasis. It is due to the infarct only. This is called the three-territory sign. Three-territory sign means infarct occurring in multiple territories, not fitting the one arterial territory. That means indicate a prothrombotic state secondary to the malignancy. And that is called the Trousseau syndrome. He
Sir,
said,
how much
pardon?
D-dimer
Pardon?
in this case, sir? How much was
No,
the D-dimer?
I didn't do that. By the time this all came later, no, by the patient wanted a discharge, I already discharged.
Can we call it paraneoplastic?
This can be called as a paraneoplastic.
Hyperviscosity.
Yeah, paraneoplastic. So what
Malignancy
happened means,
associated hyperviscosity.
correct. There is also another condition which you find in endometrial carcinoma, where they can have multiple prothrombotic states, both not only the arterial, venous thrombus also can. 1 week back, I had a patient, the lung carcinoma patient, who had developed 2 infarct, arterial infarct, 1 venous thromboembolism, venous thrombosis in the right leg, and 1 pulmonary embolism. Because he had a malignancy in the chest. So the thrombotic, that indicates that it's a hypercoagulable state. That is why it is occlusions occurring in the arterial as well as the venous side. This is a Trousseau syndrome is a hypercoagulable state associated with advanced cancer and can present as acute infarction, non-bacterial thrombotic endocarditis, and migratory thrombophlebitis. Several types of cancer reportedly cause malignancy-related ischemic stroke, including lung, gastric, colorectal, gynecological. Often the lung cancer is the most frequently associated malignancy-related ischemic stroke. The above patient had a cecal cancer. The precise pathophysiology of malignancy-related ischemic stroke is still unknown, maybe multifactorial. It stems from non-bacterial endocarditis or intravascular coagulation caused by hypercoagulability in the presence of malignancy. Furthermore, elevated levels of circulating cytokines in patient malignancies, including tumor necrosis factor, interleukin-1 may damage the vascular endothelial cells, heart valves, leading to formation of non-bacterial endocarditis related vegetation. So 3 territory sign defined as several infarctions, 3 cerebral vascular territories of bilateral anterior posterior circulation is useful and a characteristic MRI finding of Trousseau syndrome. Okay.
Okay, sir. So, but this triple territory, in fact, we usually look for any cardiac source of emboli.
Yeah, definitely. That is the first thing to do. That's the first thing to do. It's already been the first thing that we sent for cardiology workup. They did not find any Holter monitoring was done, nothing, atrial fibrillation. Then we said we'll think of this particular entity. And by the time the patient managed money and all, it became late 2 weeks later. That time we picked up this. Okay. Shall we close?
Okay, sir.
Any questions?
Thank you, sir.
Okay. Thank you. Good night. See you next week.
Thank you.
Good night, sir. Good night, sir.
Good night.
Good night, sir.